afternoon, everybody. Thank you again very much for joining us here today. My name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative. And we're very happy to be putting on this program today along with Jefferson Health. So we're joined by three fine geriatricians from the Jefferson Department of Family and Community Medicine. So Dr. Brooke Salzman, Dr. Beth Collins, and Dr. John Antonio. We're going to be guiding us in some discussion today around advanced care planning with lots of time for your questions. And again, as we mentioned, there are lots of great resources in the back that will also be relevant for our discussion here today. So I'm not going to take up any more of our time here today, and I'm going to turn it over to Dr. Salzman, Dr. Collins, and Dr. Antonio. Thanks.
Thanks, David. So everyone, welcome. Thank you so much for coming. I'm Dr. Elizabeth Collins. Please call me Beth. That works. Or Elizabeth, whatever you want to call me. But thank you for coming out. This is a difficult conversation to start and to discuss with our loved ones, but one that we all think is incredibly important, and one that isn't talked about often enough. So before we kind of get started with our part of the program, I just want to kind of turn it back on you and see kind of what do you know about advanced care planning? And what does advanced care planning mean to you, I guess? Sure.
Well, I have a medical directive, and I chose a person my note can say, let him go when the doctor's my sister can.
Okay.
But someone said they weren't sure that I should reconsider it, and I don't know how, so I'm here today to find out what should be in it and what.
Sure.
I'm going to go back and read mine and see what's.
Great. Yeah, thank you for coming, and thanks for having that in place. That's an important first step. Yeah. Anyone else have any thoughts about advanced care planning? Yeah.
I think it's a will.
Okay. It's a little bit different than just a will. A will typically, when we talk about it, takes care of the legal and financial parts of of your estate and your affairs. We're primarily focusing on the medical part today, but there's something called a living will that's part of the advanced care planning. Yeah, totally. Anybody else? Thoughts?
I guess my concern is, with advances in medical science and doctoring that at the time of my death or approaching death, maybe things would have changed and I would have been getting something in my advanced planning statement that I might not feel safe. But I guess that's the point of having somebody in charge that would know my wishes.
Exactly. I think, we talk to people so often about getting a living will or some written document that we'll discuss a bit more today to say what you want. But even more important than that is finding someone you can trust to make those decisions for you. Because again, we can't foresee every possibility that could come at the end of your life. So having somebody who can kind of think in place of you is the most important component of all of this. Yeah. So we definitely want this to be interactive, so please stop us at any point for more questions, for comments, anything like this. We're going to play a brief video just to kind of go over the nuts and bolts of advanced care planning and what it is. And then we're going to talk a little bit to reinforce what we learned in the video, and then we'll open it up for questions and discussion, okay? And then we'll probably kind of talk you through the handout that I passed out for you. It is one of the advanced directives that you can use in the state of Pennsylvania, okay? Take it away.
From NIHseniorhealth.gov, built with you in mind.
Written instructions that let people know the kind of care you want if you are seriously ill or dying are called advance directives. These are official documents that state your wishes for medical care in an emergency and at the end of life. These include a healthcare power of attorney, a living will, a DNR or do not resuscitate order, and a POST or physician orders for life-sustaining treatment.
A durable power of attorney for healthcare is a legal document in which you name someone your healthcare proxy. That is the person who would make healthcare decisions for you in the event that you could not make them for yourself. Durable means it remains in effect even if you become unable to make decisions. A living will records your end-of-life care wishes. It also spells out what life-sustaining treatment you do or do not want if you are in the last stage of a fatal illness or permanently unconscious. You may wish to meet with your healthcare provider to discuss treatment options for a variety of medical situations before preparing a living will. A Do Not Resuscitate or DNR order tells healthcare providers not to perform cardiopulmonary resuscitation, also known as CPR, or other life support procedures if your heart stops or if you stop breathing. A DNR order is signed by a healthcare provider and put in your medical chart. A new alternative to the DNR is on the horizon at some hospitals. Called an AND, or Allow Natural Death Order, it ensures that only comfort measures designed to provide excellent control of pain and other symptoms are taken. A POST form, which stands for Physician Orders for Life-Sustaining Treatment, is created specifically for patients with serious advanced illness. A POST form provides standing, actionable medical orders concerning end-of-life care. Patients can create a POST by discussing the treatment options with a healthcare professional, who then signs the form. Research shows that patients using a POST form are more likely to have their end-of-life care wishes honored.
The time to plan for end-of-life care is before you need it.
It is best to create an advance directive while you are still relatively healthy. Some people hesitate because they aren't sure what they want or they worry about changing their mind. The advance directive doesn't take away your authority to make healthcare decisions while you are able, and you can change an advance directive at any time.
To learn more, check out the end-of-life module at www.nihseniorhealth.gov.
Okay. So before we kind of start going over our little part of the talk, any thoughts or questions that come up after that video?
I'm just curious, the do not resuscitate, isn't that also included in the advanced directives?
So it's a little bit different. So
Advanced Care Directives.
So typically an advance directive is most people have one, the durable power of attorney, which is the person that you appoint for to make decisions for you, and the other is something called a living will, which is in the case that you were terminally ill and in a coma. That means we weren't able to get you. We weren't able to resuscitate, or we weren't able to bring you back. Would you want us to keep trying, or would you want us to perform resuscitation? The DNR order is a little bit different, and we typically recommend it for people who are pretty medically ill at the end of their lives, to say that in any event that your heart were to stop or you were to stop breathing, you would not want resuscitation. So the living will only applies when it's been determined essentially that you're at the very end of your life. I don't know if you can speak more to that, Brooke, or clarify.
I agree that just exactly the living will, when you put, and we'll talk a little bit more about what you think your decisions would be if you were really sick or at the end of life. You can put general things in a living will, like you don't think you'd want to be maintained on life support or want a feeding tube, or different things you can stipulate. So that's kind of theoretical, because it's for when you're in that state. But a DNR is an order saying you're in that state and that you under no circumstance want to be resuscitated.
Okay, it's slightly different, and even some physicians don't quite get the difference between those two things. So, yeah. So I think we'll start chatting a little bit more from our slides.
Can I ask?
Yeah, sure, absolutely.
DNR, is that done by an attorney also then?
So no, the DNR is done by a physician. Yeah. And same with they talked just briefly about the physician orders for life-sustaining treatment. That's similar, except a DNR is just kind of in one setting. So if you're at Abington Hospital and they ask you what you would want them to do and you say DNR, that's just at Abington.
Okay, so if you come down to Jefferson, you need to know.
Yeah. So the POST is essentially a DNR you can take with you. Okay. It's a slightly different.
And does that come from the hospital also?
That comes from a physician, yeah. So that's something a physician does and you can take with you. Like oftentimes someone on hospice treatment or who has terminal illness has a POST, and that way if they're at a nursing home, a doctor's office, any time that they're in a healthcare setting, that applies. Okay, so I want to talk a little bit, just to kind of reiterate some of the points that were in the video. So when we talk about advanced care planning, we're talking about making decisions about the care you would want to receive if you weren't able to speak for yourself. And again, this is incredibly important, and I think a point that people get confused often about is just because in your living will you said, I don't want to be resuscitated, doesn't mean that we're not going to ask you if you have the ability to make that decision. Okay, the living will only comes into effect if you're not able to speak. Okay, so we will go with whatever you say at the moment. All right, ahead of everything. So just a couple to kind of talk about the gravity of all of this, because of accidents or illness and kind of the progression and the natural course of disease, about 75% of people get into the position that they're not able to speak for themselves at the end of life. So that's why, I think a lot of us wish that we'd passed peacefully in our sleep, or we just drop dead one day. I think if anybody could choose how they'd die, that's how we would choose it. Unfortunately, the reality is that people tend to be very sick over a long period of time, and tend to have hospitalizations in and out of the hospital and get gradually more sick, and it tends to be a more prolonged course. And that's even getting kind of worse as medical care gets better and people are living longer with chronic illness. And certainly we as doctors, as providers, want to know, how we can best take care of you, how kind of what your wishes are about what you want to do. So there are a couple of parts of advanced care planning, and we're going to be talking through some of these today. First, you want to choose who your medical decision maker is, and certainly that's not something you have to do today, but I hope that it plants the seed for you to think about if you haven't already identified somebody. And then we want to talk about what choices are we making. So as Brooke was saying, determining things like whether or not you want someone to use CPR or put you on a breathing machine, or to give you artificial nutrition, or hydration. Those are all things that go into an advanced directive. And then finally, once you've made those decisions, completing the actual form, and we'll talk about that a bit. Okay. So what is a medical decision maker? So really, this is a person who can make healthcare decisions for you if you weren't able to. So somebody who can speak for you. And it's a little bit tricky kind of in the semantics of all of it. So we want somebody who thinks in place of you, not based on their own values. Who wouldn't make their own decisions, okay? So they're making decisions on part of you. There also, you may hear terms thrown around like healthcare agent, proxy, or surrogate. That all means the same thing. Power of attorney is often kind of how we talk about it. Durable power of attorney, all the same.
Something that I think is really important for the LGBT population specifically is this issue of surrogacy. So if somebody doesn't have a designated power of attorney, if you haven't chosen somebody, in Pennsylvania specifically, there is a hierarchy of people who are related to you who would be the ones to make decisions. So it would start out as if you have a spouse, a legal spouse, that would be the person. If you, then following that, if you have children, following that would be parents, then siblings, then you start getting into cousins and other extended family. And so oftentimes, I know somebody said that it's not their sister because they wouldn't be able to do it. I think that's really important to know. If you don't make a decision, it's going to be based on that surrogacy, and that's not always the person who knows what you would want the most. I think for our population specifically, I think we have to be mindful of, we may not have children, we may not have families that we're close to. There may be other things going on, so really understanding who those people are in your life, who can speak the best for you. Sometimes it could be your best friend, sometimes it could be a colleague who knows you well. There's lots of different forms of this, and it doesn't have to traditionally be a family member. But I do really think that, as these guys were saying, these are really, I think, this is the most important point to make here, that designating a person who you think can represent you if you were unable to talk for yourself. All right.
Okay. So what are some of the components of a good medical decision maker? First of all, they need to be over 18. Ideally, this is not a burden we put on children. Someone who can talk to you about your wishes, and someone you can be open and frank with about what you would want, and someone you feel comfortable talking about your medical issues with, which is another big thing, because they're going to need to know all the nitty-gritty details, so that potentially at the end of your life. And more than anything, someone you can trust to do what you would want to do if you were in that situation. And another, when you're thinking about this person too, make sure that it's someone who's not afraid to be an advocate for you and to speak up and ask doctors questions, ask the nurse practitioners questions, ask all of the staff at the hospital questions about what's going on. Just a small stipulation, just make sure it's not someone who is at your hospital or clinic or who is kind of medically related to you. It just means someone, so your doctor can't be your power of attorney, for example.
And something else to add to this is, I often see patients in the hospital who have somebody who's been designated, but they haven't told them. You haven't talked to them about it. So
that's pretty common.
It seems crazy, I know, but it happens all the time. So if you do pick somebody, I think it's an opportunity to talk about it. If they're able to come to a doctor's appointment with you and talk with your provider about that together, so they can hear you have that discussion together. I love when we can make that happen. I think that's really the best way you can do it. But make sure that they're aware of this role, that they're willing to do it, and that they know the things that you would want.
Because sometimes we worry about burdening someone by asking them to do it, but if we're clear about what we're asking them to do, kind of what we would want, we're actually, in a sense, relieving them of the burden of trying to make a difficult decision. They're just making a decision on your behalf based on what you've told them.
Yeah. So again, kind of what John was saying, what happens if you don't choose someone? Someone is, we find the next of kin is kind of how it goes. So again, if you have a legal spouse, they would be the person we would go to first, and followed by children and parents, and so on. So if there's someone who is not legally related to you, someone who is not blood related or legally related to you, then make sure you stipulate that person.
Does it have to be a person? I mean, there are nonprofits, for example, that provide care for elderly people.
So we've seen something, that's an excellent question. So the question was, does it have to be a person or could it be a guardian agency or something like that? We've seen that sometimes. Typically, best case scenario would be a person, you'd be able to designate somebody, but in those instances, the guardians, typically in my experience, from what I've seen, will typically follow doctor's recommendation, which is usually the providers taking care of you will have in mind, okay, we have to make sure that we don't do anything to violate this person as a person, make sure that we protect them. But that would be us assuming that we know what you would want as a person. And so the guardian agencies will usually go along with what the doctor has said, not necessarily knowing specifically what you would want. So I've seen it kind of get contradicted. I do, in any situation if possible, recommend finding a person who you trust to help with that. I know that can be hard sometimes to kind of find somebody who you think could do that. That's a challenge.
Yeah. And sometimes we can have, say we have a really big family, and your doctors are trying to get a consensus. Say you have 5 children or something, and sometimes it could just be helpful if you have a lot of people who you would think about helping out in this type of situation as being the spokesperson, because it can be more confusing if you have several different opinions kind of competing, or kind of in talking with the doctor, kind of having that one person can make it easier.
Yeah.
So the person I have doesn't live in this geographic area. They're signed on in my advance will, but can they from a distance just sign papers and
So they actually don't need to sign any papers. The ideal person would be someone who the doctors would or the medical team would easily be able to contact. So as long as you know that your doctor, that any hospital you're in has their information, that's kind of the most important part. Yeah, and they don't need to be in the hospital with you to make decisions.
Does your provider have that information? Yes. Your provider has that? That's really important. That's a point I'd like to make. You can have this person. I'm sorry, won't get you. If you have this paperwork and it's hidden away in some drawer in your bedroom, no one's going to know when you end up in the hospital. If that was to happen, God forbid, that you end up in the hospital, no one would know that. And so it's really important for your primary care physician to have that information. A lot of times our lawyers have it, and that's all well and good, but we might not know who your lawyer is when you're in the hospital. So your doctor is going to be the best place to make sure they have a copy.
You're getting back to allowing people to make decisions who are far away. When the time comes, are they really going to allow a voice on a telephone to make a decision? Remember, the people who actually have to pull the plugs and do the treatment, they don't know who that person is, or if they're the actual person. I can't see that actually happening, that they're going to go by your wishes and allow that voice to make a decision. Because wouldn't they be liable?
So I think the question that comes in there is, what are the things that we're doing? And ultimately, as physicians and as medical people, our number one thing is to do no harm. If we are looking at a situation and we have a document, usually we'd like to have a document that will tell us who is the person making decisions, and often that will tell us what somebody would want. We usually go along with what that says, but we start to get suspicious or question what's happening if it seems like it would not be helpful to the patient to do whatever measures they would be. Sometimes it's not always pulling plugs. Sometimes it's doing X, Y, and Z intervention. So we usually make sure that the patient's safe. As long as the patient's safe and the plan is reasonable, we follow along with that. But as much as I know families are, transcontinental, across the country, whatever else, I do think there is something to, if you can, find somebody who is available to be there. Now we do a lot of what's called telemedicine at Jefferson, where we can video conference people. Everybody has FaceTime on their phone. You can pop on the thing and I can talk to somebody. We do that with families all the time because our world is different now. People live far away. So we do that all the time to kind of meet with people and have like a conference. But if possible, I know I'm not putting a lot on you guys, if possible, finding somebody who is geographically local, I think often helps, and they're often able to advocate better for you if they're here. As much as we like to call folks and things like that, if somebody's here in the hospital, they often advocate much better for you.
And I think if someone is designated that decision maker, certainly that's the person that the doctors are going to go to just to discuss what's going on, to talk about different options. It's not kind of a this is what it says, just kind of a quick decision. That they would talk with the medical decision maker and make sure everyone was on the same page, hopefully, and it made sense. So if there was, because again, every situation is so different, we can't predict, we can't draw up a plan for every single scenario, that it's going to involve some discussion.
Yeah.
I think it's also, this is an opportunity to speak to your primary care provider about these things. These two specifically work as geriatricians in the area, and they have conversations with their patients all the time. So if I see somebody in the hospital, I often will call their primary care doctor and say, hey, could you tell me something about this person? I just had somebody today who I saw upstairs in the hospital who I was able to reach out to their primary care doctor to get some background. Very helpful in understanding what this person would want. They were able to really speak on that. I was then able to share that with the family and the people who were making decisions and they didn't know what to do. So that helps to really put things together. So I think this is an opportunity. This is a really good chance to talk to your primary care doctors about what you would want if something was to happen, so they know. They can put it in their record, they can have a copy of that, and if something was to happen to you, the team in the hospital will often get in touch with them.
Okay. So what are they making decisions about? I think that's something that comes up often. The thing that comes to mind most of all is whether or not to restart your heart or to put a breathing tube in. That's only part of the puzzle, however. So this person would be able to choose, if necessary, hospitals, doctors for you. They'd be able to determine if you needed a rehab facility after you were hospitalized. They would be able to choose that rehab facility for you, or a nursing home if you were to need it. They'd be able to help make decisions about medications and tests and invasive procedures that you would have. And then they can also, again, look at your medical information, and doctors and nurses can speak openly to them about your condition. And then finally, when you do pass away, they can determine what happens to your body. Yeah.
So we have another video to show you that I think will really illustrate a lot of these choices, and this has lots of opportunities to kind of have conversations, discussions. So as you guys think of questions, either write them down, or we're going to pause enough that you'll be able to have a chance to speak up. I think that's a good opportunity to kind of pause and think about and maybe reflect, and if you'd like to share about what are the things that are most important for you in your life. What's the thing that makes your life worth living?
So in one of the in the handout we gave you, which is the Pennsylvania Advanced healthcare directive form. This is an example. There's several different versions, and I can pass around some other examples, but this is one actually from where the video's from, called Prepare for Your Care. And if you turn to page 6, the first part is about choosing a medical decision maker. And this is the part where people are contemplating kind of how to make these healthcare choices and kind of what matters most. And one of the ways to think about it, they have these 2 lines. The first line is talking about today in your current health and what your current goals are, and to have your medical care align with those goals. So some people, again, their goal is most of us when we're in good health is to live as long as possible, to undergo most treatments no matter what. And on the other end is my main goal is to focus on quality of life and being comfortable. And then under that is more thinking about when someone is very sick and at the end of their lives, how those goals may shift a bit. Sometimes if we know that we are sick or near the end of life, our main goals may change to focus on quality of life and being comfortable. But everyone is different in this regard.
Any other thoughts before we restart the video? Yeah.
I think it's interesting to try to imagine whatever we like. So, like when it says comfortable, like I don't really know if the breathing tube hurts or like which of these things, what is uncomfortable really. I don't want to be taught to lie if it's like a painful state, and I don't really know I have no idea what it's like. So yeah, like I don't really know how to make that kind of decision because I've never had a feeding tube, I've never experienced a transfusion. How do you? Maybe it's not.
Yeah.
What do you mean by uncomfortable? Like how uncomfortable is it? It's like for each of these things, I just don't know.
It is. It's so hard to be theoretical about, and actually we know that most people change their mind over their lifetime and after they've had different experiences. Some people, after they've gone through something, they know they've been through it, they're willing to go through that discomfort, and on the other end, some people go through something, found it really distressful and never want to do it again.
I think this is another good opportunity when you're filling this out. I think often one of the things we do is we often see lawyers to fill these things out. I think that seeing a physician or a medical provider to help you fill these out, this is a great opportunity. Tell them what it's like to be intubated. Ask those questions to your provider, and they can really paint a picture for you of what that looks like. And again, exactly what you were saying, it's very subjective. What's uncomfortable? What's uncomfortable for me might not be uncomfortable for you or for you, but you might think it would be agony. So everybody's different, and so I think that's one of the real challenging pieces of this. But I think more philosophically, thinking about what are the things that are important to you in your life. Is it being home independent, being able to walk, being able to drive, being able to eat? Those are things that will, I think, determine what makes sense for you. And if you're willing to forego certain things, certain interventions might make sense. So it's not black and white. It's the tricky piece of this.
Question number 1. What is most important in your life? Family or friends? Religion? Living on your own and caring for yourself? Not being a burden on your family? Hobbies? Pets? Something else? Take a moment to think about this.
So these are heavy questions, right? So certainly not ones you need to answer today, but things to think about. So one thing that comes up often that we see a lot is, fortunately, many people are lucky enough not to have had family members who or loved ones who were in the hospital for a long period of time and had a serious illness. So we get a lot of our experiences from TV. One thing we know on TV is that resuscitation efforts, or CPR and a breathing machine, tends to be almost always successful, when in fact, in reality, it's quite the opposite. So it's not successful most of the time. So something to keep in mind and keep in perspective when you're thinking about what it looks like on TV.
Anybody have any thoughts on this? Does if thinking about an experience you had with a friend or family member who went through something like this, does that kind of bring back any thoughts or kind of shape your beliefs in what you would want?
I found that had a stroke, couldn't speak, and needed a feeding tube, and I was given I had to make a decision, and I chose a feeding tube. He lived for about 2 years, and some of that time he was all right, he was happy. Other times he was really mad and angry at his condition. So, the feeding tube part is also, my mother had Alzheimer's, and she was on the feeding tube. So I wonder about the feeding tube scenario, strokes and Alzheimer's, when it would be appropriate, when not appropriate, and what the current thinking is on that.
It's a very hard job to make those decisions for people, and I know it can feel like a burden sometimes. I think the things that we know about feeding tubes are some situations it makes sense to do them, and sometimes it doesn't really make sense. And so I think that would be, I usually leave that as one of the questions where I talk to the medical team about what makes sense for this instance. There's never a global answer as, in this situation it makes sense, in this situation it doesn't. But I think getting the recommendations from the people taking care of them are really how you know. I think if somebody has bad cancer and they're not able to eat and they want to make it to their kid's wedding, or they want to take a trip that they've always wanted to do, sometimes getting a feeding tube may make sense in that sense. And other times if somebody is not able to speak, not able to eat, kind of trapped in a bed, I think often in that sense a feeding tube might not make sense. But it's very situational, and I think this is where you have to be clear, yeah, I would want this, yeah, I would not want this, to the person who's making a decision for you. And if you're unsure, giving them permission to take recommendations from the doctors taking care of you is often what I recommend also. Maybe ask the medical team what they think. And if they say yes, then you should go for it. If they say no, then maybe you shouldn't. No, that's not a great answer. It's hard, it's tough stuff though.
Yeah.
Anybody else have any thoughts on this? Today in your current health, at the end of your life, these are important things to think about what your focus would be at those times. And it's going to be different throughout your life. But these are important questions to ask yourselves.
Many people refer to advanced care planning not as like a one and done, but as a process, or a conversation over our lifetimes. Just as, as our circumstances change and our feelings change and we have different experiences. So the idea is hopefully just to get the conversation started, to not make it such a taboo topic, to encourage you to talk with your doctors and your family and friends, so that you can, over time, figure out what you may want in different circumstances and be able to communicate that to those who may be helping out making those decisions.
I know this topic can be difficult because things are so individual for each person. But does anyone have any particular thoughts that are going through their head? Any questions that have come up that you're willing to share?
Is there a way to indicate like you don't want to be kept alive if they know that you're suffering? Is that a thing? Because I feel like it's a lot of it's saying quality of life and mostly quality of life. But what if you just say you don't want to be kept alive in pain? Is that Is there a way to do that?
Absolutely. I mean, there are a lot of cookie cutter forms, and I can hand out some other ones that are all kind of approved forms. And this is something that's easy, that you know, things that you can fill in and sign. Here are some other wishes. One's called the 5 Wishes. One's called the Conversation Project, and one's the Jefferson Advanced Directive. So there are many different forms, but you can put into writing. It's kind of, you can put in, you know, that you would want certain treatments, but if, you know, having control of your pain, or again, these other things that are very important to you, that if you're uncomfortable, you wouldn't want those interventions.
Something as a plug, the LGBTEI is going to be hosting an event on Saturday, May 19th. They're going to be hosting one of their conversations that kind of piggybacks on this topic. And I think it'll be a longer workshop, a 2.5-hour workshop, where they're going to really focusing on helping you fill out some of these things, looking over different documents. So I think that would be a great opportunity to kind of continue this conversation. I think this is a really good way to start thinking about it. But also kind of, I think the event on Saturday, May 19th, 12:30 here, that'll be an opportunity to kind of take it a step further. I think we're out of time, right?
Yeah, I have a couple minutes if there are any lingering questions, but we should start wrapping.
Anybody have any other questions? Thank you so much for
Thank
coming
you.
out. Thank you for your attention.
Well,
Thank you.